Okay, I think we should. Okay, I think we should make a start. It's 2 minutes past the hour. So thank you, everyone, for joining us for this seminar. It is my pleasure to introduce today's speaker, Alfonso Flores-Lagunes. Alfonso is professor of economics at the Maxwell School of Citizenship and Public at Syracuse University. And Alfonso will be presenting the effects of Vietnam-era military service on the long-term health of veterans. So just before we start the proceedings, as usual, the kind of housekeeping stuff, could you please click mute if you are not muted already, so that there is no background noise when Alfonso is presenting. Could you please write your questions in the chat, or say that you have a question or something like that, and we can unmute you whenever there is. So Alfonso is going to take a few pauses during the presentation to answer questions, so every 10-15 minutes. And finally, the webinar or the seminar is being recorded as usual and will be available along with the paper sometime next week. So with that, over to you, Alfonso. As agreed, 1 hour with interruptions, and maybe if not, there are not too many, we can leave the last 5 minutes for any last minute questions. Thank you.
Excellent. Excellent. Thank you very much. It's great to present here, and I thank you very much, all of you, for tuning in. And this is a paper. The title was already mentioned, and it is joint work with Shinton Wang, who's also in the audience, and Carlos Flores. And I should say that we have this disclaimer down here about the use of restricted information from the National Center for Health Statistics. So this is a topic that there's been a lot of written about, and we believe we have something new to add to this topic. And in particular, in the context of the United States, veterans have been documented to be, on average, less healthy relative to non-veterans, mainly in general social science journals and reports from US Veterans Affairs offices and so on. And at the same time, there we go. Students have documented a sharp increase in disability compensation by veterans. This has kind of increased sharply, 55% between 2000 and 2013, in spite of the veteran population in recent years in the United States decreasing by 17%. And this increase has been reported to be more notable among Vietnam-era veterans. And there has been these recent studies in economics that have analyzed this kind of dramatic increase in transfers, and they have basically documented some specific policies that have given rise to this increase in expenditures, and they try to relate it to health conditions, for example, claims for disability and so on. Some of the papers that have been in this line of work are the ones you see there: Angris et al., Otter, Singleton, and many other papers. But when they try to relate these increases in transfers to the health of the Vietnam-era veterans, the literature typically estimates causal impacts of this military service on veterans as inconclusive. Sometimes small effects, sometimes no effects on the long-term health of veterans at all. And we are trying to go deeper into the analysis of the effects of military service on veterans' health to see if we can uncover what might be going on there with this disconnect in the literature between higher take-up of benefits related particularly to disability and the lack of an effect of military service on the long-term health of veterans, at the very least inconclusive studies. So you are all familiar with what might be the problem trying to estimate these effects. Well, the problem is selection into the military service, which means that men with certain pre-induction traits may be more inclined to join the military relative to those that never joined the service. So all of these papers try to exploit some kind of exogenous source of variability. Many of them you might be familiar with. For example, they use the US Vietnam era draft lotteries in order to estimate effects on health. All of these papers that you see here concentrate on health, but it has been used more generally to estimate effects on labor market outcomes, on crime, and so on and so forth. And these studies, particularly important for what we are going to do in this paper, are the ones that I had in mind, finding either weak evidence or no evidence at all of health effects from military service. As you can imagine, to exploit these sorts of exogenous variability, they are using the US Vietnam era draft lotteries as an instrumental variable to estimate these effects, right? And if the effects are heterogeneous, as they likely are, then those studies will be focusing on what it's known as the subpopulation of compliers. In this context, and I will go into that a little bit later, those will be the individuals that are complying with their draft lottery assignment. And they turn out to be a fairly or relatively small percentage of all the veterans. They comprise about 1 in 4 of all veterans. So the evidence, the finding weak or no effects from military service on health, basically is concentrated on these 25% of veterans during that era. So what we do in this paper, we go back and try to explore this same question. We analyze the short and long-term effects up to 40 years after the conflict of the Vietnam era military service on a comprehensive list of health outcomes and behaviors. And this comprehensive list is because we're using the US National Health Interview Surveys, which is explicitly designed to look at items related to health. We are going to be, in principle, following the prior literature, focusing on compliers, estimating effects for them, but we are going to go beyond that, and we are going to estimate non-parametric bounds on the corresponding effects for volunteers. If we think about the population of veterans, we can think about that group as the treated group of interest, and that group is comprised of compliers and volunteers. So if compliers account for about 25% of all the veterans, then volunteers will be accounting for about 75% of the group. So the statistical inference that we conduct for the group of volunteers is going to catch a larger proportion of this group of veterans. And it turns out that once we construct non-parametric bounds on volunteers, then we are going to be able to construct bounds for the whole treated group. And as another point that or contribution of this paper that I am not going to be talking about too much today, we also assess the validity of the draft lotteries in IB in the context of health outcomes. I will just mention it briefly a little bit later, but due to time, I will not go into the details about how we estimate that or how we statistically assess that particular aspect of the instrumental variable. So let me go over the preview of main findings and then make a pause. As I was saying, something that I will not go into a lot of detail, we find no statistical evidence of invalidity of the draft lotteries IB. I will at least try to motivate why we might have expected that it is not a valid IB in the course of the talk. Then we move on to instrumental variables estimates that are going to be point estimates of these military service effects. And we basically find or replicate the finding from the prior literature, namely that there is no consistent evidence of statistically significant effects. Then we estimate bounds on the same effect for volunteers. And what we find is a clear pattern in which shortly after the end of the conflict, there doesn't seem to be any statistically significant effects. But then they start appearing over time, and pretty much after 24 years, they start coming up with more and more note. And as an example, if we take one of the many outcomes that we have, activity limitation, we find that after 24 years, there is an impact of military service of a higher incidence of activity limitation by 7.1 percentage points, representing 57% of the non-veteran mean. And by 40 years out, or up to 40 years out, we document an effect of 5.8 percentage points, which represents about 30% of the non-veteran mean. We use this to estimate effects for all the group of veterans. And perhaps not surprisingly, since volunteers are the bulk of the group of veterans, we find detrimental effects as well that appear over time for them, pretty much in line with the effects we document for the volunteers. And those are the main findings of the paper. This is what I am going to do in the rest of the talk, and I will just make a pause here. I haven't been checking the chat, but I see there is a question. Yeah, that's a very good point. The question is, how do you deal with those who died during service and those who died since service? I am glad that you kind of parse out the question into two parts. Unfortunately, we are not going to be able to do much about those that died during service. But we have an indirect way of looking, to some extent, at those that die since the end of the conflict. So I have it all the way until the end. But the short answer is that we document effects of military service on mortality, and I will have to qualify it quite a bit later. But the effects that we find on mortality are not that large for what we can tell, and they would actually imply that our bounds, the results that I'm going to show you later, would be actually a conservative estimate of the detrimental effects, health effects of military service during the Vietnam era. I can talk more about that as I go on. Okay, not sure. I don't see any other questions, so I will continue then. So this is the outline of the presentation. I'm not sure. Well, I am guessing that you might be familiar with the Vietnam era draft lotteries. If not, basically it is related to the following in very succinct terms. Men born in particular years, 1944 to 1950, were subjected to the Vietnam era draft lotteries. The main draft lotteries that happened at a national level in the US occurred in 69, 70, and 1971. And they were implemented using these random sequence numbers that were based on the date of birth. And then conscription happened based on the order of those numbers until the manpower requirements were met. So at the time, there was uncertainty as to what would be the cutoff. After the fact, we know that what the cutoffs were, and we use those cutoffs to basically construct a binary variable that will tell us whether the person was eligible to draft or ineligible to draft. Now, something important, and that will be used as the instrumental variable. But something important to keep in mind, and I will come back to this in several different parts of the talk, is that somebody that was eligible to draft according to this procedure does not necessarily mean that that person served in the military. Why is that? Well, males could volunteer to serve at any time when their lottery numbers were high. And there are even some anecdotal evidence that people who were afraid of having a low draft number, maybe they would actually volunteer in the Vietnam era in order to get some kind of a preferential treatment on where they would be serving and so on and so forth. There's also the fact that draft eligible males were subjected to medical, physical, and mental examination to determine qualifications for military service. So I can be eligible to draft and then show up at the office where I need to do my pre-induction, and I will be given preliminary medical and physical exams. If I do not pass those exams, then I will be in a way rejected by the military, and that will show up in my data as being draft eligible, but not serving in the military. And after the pre-induction, there is another kind of filter that happens at induction, where more medical, physical, and mental examinations are administered. So there are a number of different filters that will be related to our outcomes of interest, health outcomes, right? At the time, medical, physical, and mental examinations. And then there is a range of avoidance behaviors that have been documented in the literature, even in the academic literature, like, for example, college attendance, marriage and fertility, incarcerations that made people fail the moral standards of military service, and so on and so forth. So those are important to keep in mind as I go on, because they will be related to some of the behaviors that we are going to be using in order to justify one of our assumptions. There's a lot of sun in upstate New York, believe it or not, so I just closed my window. So the data that we are going to use is a restricted version of the National Health Survey from 1974 up to 2013. What I am taking roughly as the date of the end of the conflict is 1973, so that gives you up to the 40 years that I was telling you about. It is this survey, it is the main cross-sectional data source on health in the US, and since it is such a long period of time, it is natural that there have been changes over time in the design of the survey, particularly the questions that are asked, and so on and so forth. So what we do is we try to partition this period of time into consistent survey design features, and we came up with these 4 different survey periods: 1974 to 81, 1982 to 96, 97 to 2005, and 2006 to 2013. This is important because the results that I am going to be showing you are going to be looking at different survey periods, and this is the main reason we look at different survey periods, to have relatively consistent chunks of periods pertaining to the survey design by the statistical agency. And since questions have been changing over time, it is also true that not all outcomes are available in all periods. So the main results that I will be presenting to you today are going to be based on outcomes that are available through the 4 periods, except maybe one of the outcomes that is not available in all the periods. We also follow the earlier literature, and we focus on 1948 to 1952 for birth cohorts that were exposed to the draft. We do that because before the 1948 cohort, earlier cohorts were actually exposed also to other local drafts, and most of the literature basically just puts aside those cohorts and concentrate on these main birth cohorts that were exposed to the Vietnam era lottery drafts. And we are going to be conducting the analysis broken down by whites and non-whites. And in terms of the outcomes, I am going to, or the paper divides all of the outcomes into 4 groups. General health. The main results that I will be presenting today are about this group of outcomes. Health behaviors such as smoking, drinking. And then we have a number of different chronic conditions divided into 2 groups. The first group is activity limiting chronic conditions. And then there are other questions that pertain to other chronic conditions that are not related to activity limitations. And another important point is that to keep in mind is that all the outcomes are going to be defined or are going to be binary variables that are going to be defined as taking the value of 1 if the condition is present, namely worse health, and the outcome equal to 0, or the binary variable equal to 0, will mean that the condition is not present. So it is better health in that regard. And as you can imagine, since we are using all of these different health outcomes, it is going to be important to take into consideration the multiple testing that is going to be taking place. And all of our results are going to be accounting for this multiple testing that is going to occur within each one of the families or groups of outcomes that I just mentioned. All right, so this is a little bit about the data. Then I am going to spend a little bit of time just explaining some of the methodologies. Most of it is going to be standard. The ones that are not going to be standard are 2. One of them I am not going to be talking about too much. And the other is going to be the main source of methodology to construct non-parametric bounds on the group of volunteers and veterans. So I am actually going to spend a lot of time trying to explain first what we do, and then justify the main assumption for them. So the basic framework is just the, I would hope by now, familiar setting of potential outcomes. The main paper is this Angris, Invens, and Rubin paper that actually had an application in terms of military service effects, looking at the draft lottery. So it is exactly that framework. D is going to be the treatment, in this context, military service indicator. 1 if served, 0 if not. The instrumental variable will be denoted by the letter C, and it is going to be this binary draft eligibility status variable. And the outcomes are going to be denoted by Y, keeping in mind the way that I will be defining these outcomes. Then we have the potential outcomes and the potential values of military service as a function of the ID. This is my notation for that. DI as a function of C, which follows basically Angris, Invens, and Rubin. YI as a function of D is the potential outcome as a function of military service. And finally, there is this potential outcome as a function of both the instrument and the treatment. And the data that we observe is basically just realizations of this process, which means that there will be missing potential outcomes and potential values of military service, because they are going to be reflecting the actual assignment of the instrument. So where does that terminology that I was using earlier come from? Well, it comes from this particular framework in the context of instrumental variables that partitions the population into strata. And the partitioning happens in terms of this vector of potential values of military service. And you might be familiar with this. If so, please bear with me. What this setting yields as 4 latent strata would be those individuals that are reflected here that will be serving regardless of eligibility to draft. And these are usually known in the literature as the always takers in generic terms, but in the context of this application, they are basically volunteers, right? People that no matter what their eligibility to draft is, they are going to be serving in the military. That's why we are calling them volunteers. We have the draft avoiders, again, a more specific term related to this setting, which correspond to the never takers in the general terminology in this framework. And they are people who will not be serving in the military regardless of their eligibility to draft. And then we have the other two groups. One will be the compliers, individuals that are going to are going to serve if they are eligible to draft. That will be this part right here. And they are not going to serve if they are not eligible to draft. And as you know, probably this is going to be the group that the literature has been identifying effects for. And then finally, we have the so-called defiers. For completeness, they will be ruled out later by assumption, but the defiers are individuals that are basically just doing the opposite to their eligibility to draft status. If they are not eligible to draft, they are going to serve. If they are eligible to draft, they do not serve. All right, so let me just go over these parameters of interest, and I will make a stop to see if there are any questions. We have 3 parameters of interest for this talk. In the paper, there is another parameter of interest that I am not bringing in today. The first one is the typical average treatment effect for the subpopulation of compliers. In other words, it is the comparison of potential outcomes on their service in the military, no service in the military, for the subgroup of compliers. This is what the instrumental variables model or estimation is going to identify an effect for. In this case, this is the effect that is point identified. Then we have the other parameter of interest for volunteers. It is the same definition as above, but it is conditional on being a volunteer. AT, remember, is always takers. In this context, it is volunteers. And then finally, a parameter that is of primary importance in the whole causal inference literature, which is the average treatment effect on the treated. It actually corresponds to the effect on all veterans, all people that serve, right? Since the other groups of individuals, in particular the draft avoiders, never serve, it turns out that the treated group, all veterans, consist of both compliers and volunteers. So in a way, this average treatment effect on the treated is going to be the weighted average of the 2 effects above. So these are the parameters that I am going to identify, or that I am going to make some assumptions that will lead me to a methodology to point identify them in the context of compliers, or partially identify them in the context of volunteers and all veterans. Let me see if there are any questions. I don't see questions on the chat, so I will keep on going. These are just the standard IB assumptions that people have a lot of familiarity with, right? There are 4 assumptions. Very quickly, I will come back to them a little bit just to try to justify them in general in our setting. But the main result from the seminal paper by Angry, Siemens, and Rubin was that if you have these assumptions, number 1, a randomized instrument, number 2, a non-zero average effect of the instrument on the treatment, assumption 3, individual level monotonicity of the instrument on the treatment, which implies that there are no defiers. And finally, a very important assumption, which is the exclusion restriction, that the effect of the instrument on the outcome works only through the treatment. Then if all of these 4 assumptions are satisfied, we have the result that the local average treatment effect for compliers, the effect for compliers is point identified, right? This is what Angry, Siemens, and Rubin showed. And what we are going to, what we do in the paper, and this is the only point at which I will explain a little bit about assessing the validity of these assumptions, is we devote a section in the paper to explain how to estimate a effect of the draft lotteries on the outcome that is independent of its effect working through military service. That is a net effect, or in other terminology, a direct effect. We bound that effect, and we actually find that that particular net effect is not statistically significant for any of our outcomes. And we take that as evidence that the instrument is valid in this particular setting. And therefore, after showing that evidence, that is not direct evidence about the validity, but it is testing implications of the previous 4 assumptions, particularly the exclusion restriction assumption, then we move on to point identify, hold on to those assumptions, point identify the effect for compliers, and then estimate those effects for compliers. That's what we do. I had the information here, I had forgotten. All right, so what about the other 2 parameters? That's basically what is newer in this context, right? How do we go about identifying the effect for volunteers and for those that are, and for all the veterans? Intuitively, they are not point identified in this setting because there will be, if I may, there will be one component. Let's just focus on volunteers. There will be one component for them that is going to be point identified, right? Since volunteers always serve, we are going to be able to see their, or to estimate their health outcomes, the average of their health outcomes on their military service, which is this term. But on the contrary, since volunteers always serve, we are not able to estimate their average health outcome under the state of not serving in the military. So that is the main problem. That is the reason why we cannot point identify the effect for volunteers. And in consequence, since veterans, 75% of them are volunteers, we are not going to be able to estimate the corresponding counterfactual, average counterfactual for them. So we need to do something else. What we do is construct non-parametric bounds. And we're going to basically use the blueprint of previous work by Chen, Flores, and Flores-Lagunes that does something along the following lines. Right? We are going to use 2 additional assumptions, one of which is trivially satisfied in this context, so I will spend more time on the other assumption. The first assumption is boundedness of the outcome. The outcomes that we consider are binary, so they are naturally bounded between 0 and 1. So as a starting point, if I take the boundedness assumption, then we can partially identify the effect for volunteers. And we have a name for this type of bounds. These are called worst case bounds. And the unfortunate thing is that these worst case bounds are typically uninformative, right? So how do they look like? If we think about the following expected value, right, denoted by Y over bar CD, it is just the expected value of the outcomes, the health outcomes, for individuals that have a given value of the instrument and a given observed value of military service. So these are objects that can be estimated, right? In particular, if we estimate that effect for individuals that are ineligible to draft, but they serve under the IB assumptions, we can tell that they are always takers, that they are volunteers. So we have one component out of the 2 components of the effect for volunteers. Therefore, using the bounded outcome assumption, we can construct simple bounds on the effect, right? We will have here the expected value of Y1 for volunteers, and late subtracts the corresponding value for the expected value of Y0 for volunteers, right? But since we don't know that, we just substitute here the worst case scenario, which will be the upper bound for the outcome. And then that will give us a lower bound. And we do the opposite for obtaining an upper bound, such that this is going to be the space, the set in which the local average treatment effect for volunteers is going to live, if we just use this bounded outcome assumption. I will not go on and on, but here it is easy to show that typically the width of these bounds, the size of the set is going to be wide, and as a result, the bounds are going to be uninformative. So we are interested in using other assumptions. And the assumption that we're going to use basically relates the corresponding average outcome for never takers, which is observed, to the corresponding average outcome for volunteers. In particular, implies that in the absence of military service, the average potential health outcomes of draft avoiders are no better than those of volunteers. You can start thinking about how I am going to be justifying this assumption. I am going to be justifying it in the sense that many of the draft avoiders were rejected by the military because of health reasons, right? So what this statement is saying is that on average, draft avoiders will have worse health relative to volunteers. And then intuitively, I am just taking the bounds that I derived earlier for volunteers, and I am going to be just, instead of using for the lower bound, the worst case lower bound or upper bound in this case for the health outcome, I am going to be using that particular estimate of the corresponding average for draft avoiders as the lower bound. And the upper bound is going to be basically the upper bound that is coming from the worst case bounds. Okay, so let me see if there are any questions. This is one of the key parts, giving you some intuition about how we are going to bound these effects. Okay, I didn't see questions. I will basically not dwell on this. I will just give you the on this slide. I will just give you the gist so that I can move on. Basically, for the effect for veterans, as you can imagine, since the only source of non-point identification was that counterfactual that I showed you earlier, for the average treatment effect on the treated, which is a combination of both compliers and volunteers, the only piece that is not going to be point identified is the same piece as for the volunteers. So if I make the assumption of bounded outcome, I can derive bounds for the average treatment effect on the treated. If I further impose the assumption that I just mentioned a minute ago, then I can derive bounds for the whole group of veterans based on that particular assumption. Okay, so these are too many equations, but I just gave you the gist, the intuition. Okay, so results. I start by discussing a little bit of the assumptions, and I will go quickly on this slide as well, given the time. The first assumption basically holds by design, the random assignment of the draft eligibility. The second assumption, it's verifiable, which means that if we just look at the average effect of draft eligibility on military service, then we can tell that it is different from zero, and it is statistically significant. For reference, is between 0.13 and 0.15. It turns out that that is also the proportion of compliers in the data. The third assumption is not as straightforward as the other two, but I don't think there is a lot of controversy in the literature that it is satisfied, because we just need to think about the likely scenario that nobody would be serving in the military if ineligible to draft, but would not serve in the military if the person is eligible to draft. And this basically discards the subpopulation of the fires. And then the key assumption, the one that is more tricky, and the reason we go into the estimation of that net effect that I was telling you about to assess implications of these assumptions, is the exclusion restriction. And the reason it is more controversial is because there have been documented draft avoidance behavior, some of which I mentioned before. But as I also told you before, we find, and this is in the paper, we find that these assumptions do not seem to fail in the context of health outcomes. So to give you an idea of some preliminary estimates, under the first three assumptions in the previous slide, we can estimate the proportions of individuals that fall into the three different remaining strata. The largest estimated stratum proportion is draft avoiders. Between 64 to 66% of the individuals fall in this group. The reason I am giving ranges is because, remember, I am doing this over different survey periods, and I am also doing it by white and non-white. The estimated proportion of compliers, this will give you a sense of the size of the subpopulation for which IB point identifies an effect, is between 13% to 15%. For whites, this proportion of compliers is between 13 to 15%, kind of the same as the whole population, but it has been documented in the literature, and we find the same thing, that it is much lower for non-whites. And that's why oftentimes in the literature using the draft eligibility IB, people do not find effects for non-white compliers, because the effect, or I should say the IB, it's not necessarily that it is weak, but it is just not as highly correlated as it would be for whites. Next, the estimated proportion of volunteers is between 21% and 23%. For comparison, for non-whites is not very different, 17% to 21%, right? If we take into consideration that the veteran population is between 27 to 29% for these cohorts, then volunteers make up for about 70%, 75% of all the Vietnam era veterans. Okay, so I am going to skip this and go into some of the results finally. So the point estimated effects for compliers, what we find is very much in line with prior literature. They are mostly statistically insignificant. We also find no consistent pattern. There are a few statistically significant effects, but some of them actually indicate detrimental impacts of military service on health, but others show up as beneficial impacts. This is what I've been referring to, that other work also find very much the same, no effects or very small effects. I see that there is a question, right? Yes, so the question is whether the bounds can be modified to accommodate the case of invalid instrument. Yes, that is a good point, and that is correct. In fact, some time ago, we started this project thinking that we were going to go into the data and find that the IB was not valid, and then apply bounds that would basically do the same as I am showing you here, but for an invalid instrument, which is possible to do. But after going into the data and getting results and so on, we found that it doesn't seem to be the case that the IB is invalid. So we decided to just use the validity of the IB and produce the results that I am showing today. Okay, thank you for that question. So this is to give you an idea of the effects. These are the effects for compliers. I will be showing you some of these or more of these type of graphs. So let me just spend a few seconds. Each one of these panels correspond to, one next to the other will be for whites and non-whites for a particular condition. In this case, is activity limitation, and the different parts in the graph will correspond to different survey periods, beginning with the earlier, 74-81, 82-96, 97-05, and 2006-2013. And as you can tell, just from looking at these two, I will show you some more. Basically, the vast majority of them are statistically insignificant. Some of them are significant, like this, like for example, this one right here in 1974-81. But then this is what I was referring to, that sometimes it flips sign for a different survey period, right? Here's some other examples for fair and poor health and current smoker. Most of them statistically insignificant, some of them significant, but with the opposite sign, right? In summary, we take the evidence for compliers as showing no clear pattern. We could even say that no effects of military service on health, even in the long term, right? Even up to 40 years after the end of the conflict. So let me move on to the effects for volunteers. And for them, basically, we are using the assumption that I mentioned before, right? How do we go about justifying this assumption or trying to argue in favor of this assumption? As I mentioned or hinted before, anyone reporting for induction would go these stringent medical, physical, and mental screening examinations. And those males that are not able to pass the examinations basically become part of our draft avoiders group, that is basically this part over here of the assumption, right? And we are posing in this assumption that they indeed have worse health, or more technically appropriate, no better health than the volunteers. These are a couple of points in different papers that have basically spoken to this stringency of the medical, physical, and screening and mental examinations. For example, half of registrants in 1970 failed the pre-induction examinations, and 20% of those who passed were eliminated by physical inspections at induction, right? Very high percentage of people are turning away because they are not able to pass these examinations. Another one from 1967 to 1973, the failure rate of the pre-induction physical exam was 47%. So what I am trying to say is that a lot of people are being turned away by the military itself because they are not able to get past these medical, physical, and mental examinations. The result, right, this is completely consistent with the positive health selection into the military that abounds in the literature, right? These are just some references that basically, when motivating the selection into the military, they say, look, we would expect that there is positive health selection into the military. And remember that the assumption basically states that in the absence of military service, draft avoiders would have worse health relative to the volunteers, right? Those that are able to get into the military after passing those health screenings. Our argument follows as saying that positive health selection into the military, combined with the high correlation between present and future health, makes it possible that draft avoiders would have lower average health relative to volunteers in the absence of military service, right? And then I will skip the following. This is just more discussion about draft avoidance behaviors, some of which would be going in our favor in terms of the argument, some of them that would not. And there is a large discussion in the paper about draft avoidance behaviors and the, how they relate to our assumption. The reason I am spending this time on this assumption, and by the way, there is another thing that we do, we also document that pre-draft, this is, I guess, the strongest evidence, pre-draft, draft avoiders are considerably more likely to have activity limitations relative to volunteers. That holds for whites and for non-whites. Since I am running out of time, let me just skip this. I can discuss this assumption a little bit more. The main point, I think, of the whole paper is that what we find for volunteers and subsequently for veterans as well is that for the first survey period, we basically find no effects in terms of statistical significance. But after that, we find significant and economically important effects. This is just an illustration, and I will show you graphs like the others, and then I will stop for questions. No effect in the first survey period. By the second survey period, in terms of activity limitation for whites, as an example, we find that according to our bounds, at least, there is an effect of at least 1.1 percentage points, 9.2% of the non-veteran mean, that becomes at least 7.1 percentage points by 97-2005, and that basically remains at about a similar level, 5.1 percentage points, representing 30% of the non-veteran mean. So since I am running out of time, let me just show you a couple of pictures, and then I will stop. This is how these results for veterans look, right? You see the suggestive pattern of increasing effects the more far out you go in time. This is work limitation, the next two, self-reported poor and fair health, and finally smoking. Smoking is significant even from the start of the first survey period. Okay, so yes. Oh. I'm not sure if that is okay. So this is for volunteers. I'm running out of time, so I will just tell you that if we look at more and more conditions, and all of these are reported in the paper, we also see that these effects appear for the second, third, and fourth survey period in a number of different conditions, right? Some activity limiting related, some others not. And we have very much similar effects for the whole group of veterans, right? I will just flip through this. And let me just end with a couple of implications. So we see our results in a way as reconciling some of the literature out there, right? In other words, we believe that our results are relevant to explain the recent rise in compensations for Vietnam-era veterans. I didn't have much time to go into the details, but we find detrimental health effects for diabetes, musculoskeletal conditions, depression, and so on, which have been conditions that are related to jumps in claims. We reconcile the prior literature because on compliers, health effects had not been registered, or statistically significant effects on health had not been uncovered. But if we move past that and we look at the group of volunteers and also the group of veterans, then if you believe our assumption, then we are able to document detrimental effects for them that would be consistent with all of these. So I will stop here. The next slide is just conclusions. So let me just leave this implications slide here and take any questions you may have.
Thanks very much, Alfonso. There are two questions, I think, in the chat, and then we will see if there are other questions.
Yes, so I can see one question by John. Can you please also address why you are interested in these treatment effects? You can estimate them cleanly, but why is that your interest? So my interest, I guess, I can just circle back to these implications. My interest is that the United States government is spending a lot of money and a lot of resources in compensating veterans after their service, and something that that hasn't been well recognized is why is that, right? I mean, there are claims and so on, but there have also been changes in policies. there was, or there is a question as to whether it is health related, right? Whether veterans have a causal impact of military service on their long-term health that will justify spending on them millions and millions of dollars. So from that point of view, I guess that finding, documenting these effects in a credible way, which we hope that is what we are doing, then helps, on the one hand, understand why the jump in claims and expenditures compensating veterans, and also what the military could do, for example, in order to curb some of them. And I didn't have time to go over that, but these last two implications that you see on your screen are about smoking behavior, right? And how that might be a mediator that can be a subject of policy changes directed to curb some of those detrimental effects of military service on health.
Thank you.
Then another question I see here, yeah, you're welcome, is I am worried about the external validity of the study. Veterans then and veterans now are very different people. Yeah, that is a great point. I mean, right now, what I just explained to John is basically in terms of the internal validity of our study, right? We are documenting for these effects for the population of Vietnam veterans, who are the ones that are taking up more and more resources in terms of compensation. Your question, which is a very good one, is how does my study or our study actually help us understand better the current veterans? And I will not deny that that is an issue of external validity. I totally agree. However, in our defense, if you look at the U.S. switching from conscription to an all veteran force, military force, then I would make the argument that looking at veterans, even if they are Vietnam veterans, would be more relevant to the all voluntary force, the current all voluntary force, relative to looking at compliers with these particular draft lotteries that happened during the Vietnam era. So it is a very good point, the one about external validity. Yeah.
Any other questions? We have just about a minute. No? Great. Thank you so much, Alfonso, for a very interesting talk. And thank you for everybody to participate and those who ask questions. It's perfect time now to stop here. Thanks again, Alfonso. And
yeah,
we'll
you're welcome.
see other people, all of you, hopefully at the next seminar. Bye.
Yeah, thank you, everyone.
Thank you.